robotic TKR, I can see quite a few robotic surgeons here in the audience. So let it be an interactive session. And so my journey with technology in TKA started with some Colibri system with Brain Lab, and then Knee3, GPS from Exatech, semi-automated, and then fully automated robo. But honestly, it wasn't that great. Earlier, those results were not predictable, and those systems definitely lacked precision, and reproducibility was definitely questionable. And so then I was a bit skeptical when I was actually whether to go for robotics and whether to go for QAs, and then you can say rest is history. So is it really worth? Will it make any difference? It is just a marketing gimmick. And what about OT time, complications, severe deformities? Typical Indian scenario where patients, they do present with severe, and the patient often present late with severe deformities. So, and Pune being capital of robotic orthoplasty, close to around 17 robos now in city of Pune. And orthopedic icons you will see next couple of days here. So, so I know a small person like me, but I could achieve. And all these patients, and to be very honest with you, I mean, patients are sending patients. I mean, and those patients who I have operated non-robotic and then robotic now, and they could feel the difference. I mean, I feel that's the biggest, feedback or most important feedback. Patient has undergone non-robotic first in your center, and then undergoes robotic after a couple of years, and then he could find difference. So benefit to patient, definitely less soft tissue releases. This soft tissue releases we used to do earlier with non-robotic technique, and then less blood loss, implant placement. And I was just discussing all bilateral TKs also within 48 hours we are able to send home, 48 hours straight. 2 hours, that is the surgeon's time, and 4 hours total from anesthesia till patient is out. So complications like pin track fractures, but we could overcome those with this technique where we started putting pins in the metaphyseal region slightly, and then because this is necessary in this system, otherwise it will obstruct the path of the Miller. And unlike other systems where they are saw-based system or handheld robotics, that's not an issue if you put it slightly oblique or vertical. But here you have to put horizontal, otherwise typically taking distal femoral cut, it will obstruct the path of the Miller. And as I was explaining in this, it should be around 90 degrees. And so we'll just forward this video. So it will not obstruct the path, and then it is very easy and goes on. Last around 800-900 cases we are done, zero pin track fractures, zero. So this is one important thing which we have learned, and with this pin placement, definitely it has worked for us. Severe deformities, whether we are able to handle severe deformities with robo, it's possible. So couple of these cases, I'm sure some of you must have seen these cases earlier also in my presentation. So 74-year-old gentleman operated fractured tibia, and this is how he presented to us, and severe deformity more on the left side. And as you can see, it was tight medially, just 3 mm opening, and laterally it was 8 mm opening. And when you start planning, so you have to increase the tibia cut, you can give slight varus, external rotation. So all these things are not possible with manual technique. And so I'll just forward this. So what I did here is, can I have a pointer? So here I have increased tibia by 2 mm. I have given external rotation femur, and so flexion I could achieve 10-10 gap balance. Extension, it was still tight. So here I have given slight varus on the femoral component, and I am taking distal up because you can see there is 11 degrees of fixed flexion deformity. So I am increasing the distal femoral cut, and there with that I can achieve, and I am able to achieve good or stable both flexion and extension gaps. So such fine tuning is possible, and before you take any bony cut, which is not possible with manual technique. And these are the post-op X-rays, pre and post videos. Another patient, severe deformities and extension stem was required pre, next day, and around 3 weeks post-op. So complete correction in such severe deformities are also possible. So routine cases, routine mild deformities, it is definitely a cakewalk with this system. So severe deformities, again, this patient very tight on the medial side, and so what we did is increasing the tibial cut and giving external rotation. So this helps us in balancing the knee perfectly. And this is a post-op X-rays. So some of the patients where it was a lax subluxated knee, and definitely you are able to achieve good stable knee. Again, valgus. Valgus is one challenging scenario. So please see this, okay? The distal medial femoral condyle, it was around 30 mm. It was a big size femur, severe FFD plus valgus. But posterior resection on the medial side was 5 mm, and lateral side it was 9.4 mm. Okay, in otherwise, when we external rotate in routine case, we resect more medially. Okay, here it was lax or opening out medially and very tight laterally. So I resected more on the lateral side. So now we are worried. I mean, so I have given around 6 or 7 degrees of internal rotation in this case. So all these years we have been taught, okay, external rotation, patellofemoral tracking, how it will work. And this is the intra-op video of same patient. I mean, this is no thumb rule, patella sitting nicely, and flexion and extension, same patient. So after giving internal rotation also, patella tracking was good. And initial couple of cases, okay, I was skeptical, but now we are doing it routinely and without any issue with patella, and same patient, pre and post videos. So severe deformities also we are able to address. We'll skip and some interesting discussion point. I like to involve all these QS users here. So again, a valgus knee and same patient. So complete correction. Valgus is definitely interesting and challenging, and don't hesitate to, those who are using QS here already, so don't hesitate to give internal rotation. It won't affect your patellar tracking. So that's what I have learned over the period of time. And so he's a farmer from Latur, far off place from Pune, and pre and post video of same patient. So Akhil and Saad, I'd like to have your opinion on this video and those. So say 57, but is relatively, looking. Okay, I'll pause this. So this is the AP and lateral. Okay, we are talking about right knee. So any conventional TKR, it looks like in a simple, straightforward knee, symptomatic knee, painful, and so look at this. When you go for gap check, 15 mm on the medial side and 8 mm on the lateral side. So it was gross. I mean, as you flex, it was opening medially. Okay, and then in extension again it was 15 and 8. So so it was difficult to balance, and it is impossible to balance such knees with the manual without robotics. And so in this case I increased the valgus here on the femoral side. With this I could balance it in extension 7-7, as you can see, and internal rotation of the femoral component again. So with internal rotation I could balance and reduce the posteromedial resection on the femoral side, increase the posterolateral resection, I could balance it nicely in the flexion as well. So it was still very lax medially, and you cannot keep it like this. Okay, I mean it will just subluxate, it will just come out. And if you keep it too tight, obviously it is going to restrict flexion post-operatively. So it was, so I gave internal rotation. Please note, I mean, we were discussing this. Look at this internal rotation, 6 degrees, 7 degrees of internal rotation. And then I could balance it. So it is nicely balanced now, 9, 10. And then post-resection. And then these are the post-operative X-rays, trial reduction of the patient. Again, observe, watch patellar tracking. It was and stable in extension, no laxity at all, and then final reduction, and then these are the post-op X-rays of this same patient. So nicely balanced knee, flexion and extension. So looks good. So friends, distal femoral cut, don't go beyond 12 mm while using this system, especially in smaller femoral size, B up to C, because otherwise the cut goes pretty close to epicondyles. Upper tibia cut up to 7, otherwise it opens out. I mean, it may show 9, 9, 10, 10, but if you go more than that, then it opens out. The upper tibia cut is if it is more than 7 mm. So you may end up with 11 poly or 14 poly. So don't resect too much on the tibial side. Combined varies up to 5 degrees. And then hide implant option, I forgot to mention during those videos, is really predictable, and it is important to avoid notching. So which you can see on table. So our experience with this system is good, and learning curve is there, but 1200 plus cases and almost 99% cases we ended with 9 or 11 poly. Less blood loss, less pain, and shorter hospital stay. So I take this opportunity to welcome you all to Pune Orthoplasty course, which is going to be held on 31st May and 1st and 2nd June at same venue. Thank you very much.